This video here is going to be on basics of the spine. So I know the last video with the rib cage pretty short. This is going to be divided into two videos, plus really it's going to come into also the posture lecture, the balance lecture. So these are some concepts that we really need to be able to apply across the spectrum. So the first video here is pretty much going to deal with osteology, bones, arthrokinematics, osteokinematic movements, and that. And then the second one we'll look at a little more of the muscle component with some of the pathologies. So first, let's look at the shape that the spine should be in. So it's crazy to think, but people used to think that your spine should be completely straight. And that makes it like a steel rod, which is not compressive. So the spine actually should have these curves that we see here. Very important that we have these curves. This makes it more of like a spring, so it's absorbing shock and force. So ideally, we'd like to have that cervical lordosis, which also is called extension. So we can substitute those words. And then in the thoracic spine, we call that curve kyphosis. You could also say flexion if you want, but people generally are going to say kyphosis. Lumbar lordosis or extension, and then flexion when we lose that lordosis. And then sacrococcygeal kyphosis. So a lot of focus is going to be really on these first three in terms of what we learn at first and mastering that before we move to other areas in continuing education or something like that down at the sacrum. So those are the curves we're looking for. And this will be talked about a lot more in the posture lecture, but we need to think about how different postures are going to give us changes in the lordosis or kyphosis of the spine, and then how that will then have a domino effect on multiple other things. So everything, the spine and the foot are really the foundation of everything, and issues in either one of those areas has a cascading domino effect on other areas of the body. So in the posture chapter, we'll talk more about the plumb line and where it should fall so that we know we're having proper posture. So this is just kind of an example. If you were standing there, different points along the body where we want the plumb line to fall. We'll go in more in depth in the posture lecture. So we should easily be able to know that we have 7 cervical, 12 thoracic, and 5 lumbar vertebrae. We should also be able to easily visualize what each of these vertebrae look like. So if you found one of these vertebrae laying around on the sidewalk somewhere, you'd be able to say, oh, that's a thoracic vertebrae. So when we look at these guys, if you look over here at the side image first, our lateral view, you'll see that the body of the cervical vertebrae pretty small and not an overly pronounced transverse process. So if you come over here and look at this on this side, you see obviously it has a transverse process, but nothing like the transverse process you see in the lumbar spine down here. Then you get down to the thoracic, you see a much larger body. So if you think there's the body, here's where your discs are going to be, okay? Much more prominent spinous process, angling down, also a big transverse process as well. Then we get to the lumbar spine, even bigger bodies, where our discs would be. Very large spinous process, a lot more broad than the narrow one that you see in the cervical and thoracic vertebrae. And then a spot we're going to talk a lot about with treatment all the time are going to be here. The facets, where the vertebrae are going to meet the other vertebrae. And we'll look at that a little more when we look at actual arthrokinematics. But it's very important that we understand the orientation of these facets, because a lot of times that's where a lot of the issues at the back come from. You have tons of facet joints everywhere where the vertebrae meets the other vertebrae, top and bottom. So you look over here, let's just take the thoracic one lateral view. Look at all these different spots. That's 5 spots right there. where we have joints, and then we have all those different vertebrae, 7, 12, and 5, all the way up the spine. So really easy to have a pathology in this area. Very special joint we need to look at is between the occipital or the skull and C1, and then C1 to C2. So when we're looking at how we're getting motion, at most of the spine, you have to have a little bit of motion at every single joint to give you your full range of motion. Again, we'll look at that in the arthrokinematics portion. But when we're looking at this part, the skull, a lot of your capital, it's called capital flexion and extension. Capital flexion or extension occurs right here, where you have the articular surface for C1 and the skull, okay? So this is your atlas. A lot of flexion and extension comes there. And when we do MMT, that's called capital flexion and extension. Now we get the rotation. Most of our rotation comes from the fact that the atlas sits right on top, or sits on top of C2, and we have the dens that comes up through the center. So the dens is on C2, comes up through the center of the atlas, and that's where we get most of our rotation. So right here, this is a huge joint for a lot of flexion extension and a lot of rotation. So that's occipital in C1 and C1, C2. So that atlantoaxial joint, I guess that's not written on there, is it? Atlantoaxial is C1 and C2. That's where we get our rotation. And like all joints, we have some serious ligament action. So I'm just really going to point out two major ligaments here. So we're taking an anterior view. Let's look at this top one, this anterior view. We need to point out the anterior longitudinal ligament. I want you to see how wide this sucker is. It's really, really wide. And then if we go down to the posterior view, you'll see the posterior longitudinal ligament. And look how narrow that is. So we have a lot of disc herniations that move posterior for multiple reasons. One of them being the posterior longitudinal ligament is a lot thinner. Imagine trying to blow a disc out the front with this huge anterior longitudinal ligament. A lot harder, right? A lot more support. Well, with that support, we have reduced extension, right? You think about, well, what motion would be reduced because of this huge ligament? And we have reduced extension. Now, of course, some people are super flexible and all that good stuff, but we have extension reduced because of that. Now we have a lot more flexion motion. I mean, most of us, even if you have a ton of extension, you're going to have probably more flexion. One of the reasons is because we need to be able to bend over, work in front of us, right? You think about how we were initially quadruped, then you think about squatting down, bending over. Flexion is a very important motion. But to have that much motion, we have to sacrifice stability. And we should be noticing that throughout the body, that where we have more motion, generally we have less stability. Take the shoulder, for example. So this will allow for increased flexion, but then again, more susceptible to posterior disc herniations. So now let's take a look at those discs. So I told you those discs are on top of or underneath the bodies of the vertebrae. So the disc is a huge shock absorber. So that's the whole point, is to try to make this springy shock absorbing structure of our spinal column. So when pressure goes correctly, you can see how it's going to be distributed throughout that disc. Take an aerial view here. So if we have a disproportionate amount of force, let's say here, what's that going to do to this disc? It's going to push an unequal amount the opposite way. Take a water balloon. Think of this as a water balloon. So if we push too much on one end, it's going to push all the water to the other end. And this will eventually be the mechanism of injury for any of those disc herniations that we'll talk about in the next video probably. And then let's take a look, since I already have this picture over here. So we're talking about that. We should understand that spinal cord's going down through. We have our discs, our nerve roots, and we'll talk more about that as we continue on. But we need to be aware of, up here in the reading, cauda equina. It's called the horse's tail. So that's where the spinal cord branches off. And you're going to see that between different literatures are going to have some different things in. So, but we're going to go L1 to L2 is where that spinal cord ends and the cauda equina begins. So L2 through and L3, that junction is going to be, and below is going to be definitely the cauda equina. And why this matters to us is because when we get to neuro, this is going to be considered damage to this part of the spine, lower motor neuron injury. And anything in the spinal cord that's not the cauda equina is going to be upper motor neuron injury. And they present very differently. In fact, an upper motor neuron injury is going to present with an increase in tone and spasticity, something that people generally don't assume with spinal cord injuries. They usually assume the lower motor neuron injury, which is at its worst, complete flaccidity. So there's a lot of stereotypes that are incorrect about spinal cord injury patients, and we'll talk a ton about that, of course, in the spinal cord injury section in neuro. And there's actually going to be a link here that you can click on if you want to hop over there and learn anything about that in advance. All right, so we've talked about the curve of the spine. We've talked about the vertebrae, anterior portion of the vertebrae, the body. We talked about that. We should understand with the nucleus dividing into its two parts, the nucleus propulsus, is mostly water. So as we age, we start to lose that hydration, which means you start to lose that springiness. That's why I think it's so important to think of a disc as kind of like a water balloon that's surrounded by fibrous cartilage. So we have that fibrocartilage. And it's the busting out past that fibrocartilage or the pushing on that that actually is our herniation. And again, we'll look at pictures of this in the next video. Then another huge spot we need to look at is the difference. We need to look at the intervertebral foramen. So the vertebral foramen is where the spinal cord goes through, but the intervertebral foramen is where the spinal nerve roots go out of. And then I'll show you some pictures there, but we talked about the atlas and the axis. We talked about the longitudinal and the cauda equina. So now let's go to that intervertebral foramen. So here's a picture of someone doing extension. There's plenty of pictures in your book to look at to dissect more of the arthrokinematics. But really there are no rolls. It's all glides or slides, as this book presents with slides. So if you extend, what's going to happen is that the facet joints, and that's why it's so important to understand, look at these facet joints here, are going to slide inferior. So then with flexion, you're going to see a separation of these. So they're going to slide superior. So we need to understand that so we can understand what's happening to the intervertebral foramen, which is this space right here. So intervertebral between two vertebrae. So you need two vertebrae to have this. And this is where the spinal nerve roots come out. So we need to understand which motion is going to enlarge those holes and which motion is going to reduce the size of those holes. So extension, as you can see, is going to push the facets down. Extension is going to close the facet joints. Flexion is going to open them. Flexion will open your facet joints. And that'll matter because, well, if someone has stenosis, which again we'll talk about in the next video, which is where you have bone growth in these holes, osteophytes growing, so we're reducing that. So those nerve roots are getting pinched when someone has hyperextension. So then we need to get the patient out of that hyperextension and get a little more flexion in the spine to take some pressure off those nerves. So this is where it gets really fun to start to think about. I really enjoy treating the back because of the complexity, and it's great when you can solve a problem. So if you think about if someone has, let's see, increased lordosis in the lumbar spine, what will be happening to their intervertebral foramen? You'll see that abbreviated IVF. So we should think about how that means they're going to be closed, or closed more than they are normally. We also should understand that the person is in an anterior pelvic tilt. So if we can tilt the pelvis posteriorly, we can reduce the amount of extension in the lumbar spine, thus opening up that space to reduce the symptoms. That's why when I talked about a ton with the pelvis, we need to understand the relationship, how to tilt the pelvis and what that does to the lumbar spine. We'll talk more about this with actual treatment stuff, but you need to understand that if I tilt my pelvis one way or the other, what's happening to the IVF and what's happening to the discs. Because if I posteriorly tilt instead of anteriorly tilt, if I posteriorly tilt, what will that do to the IVF? Well, it will open it up, but it will start to push the disc posterior. So we have to weigh the risk reward of what we're doing when we're changing that patient's posture. So I don't think the arthrokinematics are too complex. We just looked at flexion and extension there. Looking at rotation here, everything's a slide. It just has to slide. So if you rotate to the right, the slides are to the left. Because if the facet joints slide left, it's going to turn the body to the right. So now you're looking to the right. Pretty easy. No rolls, just slides. Let's look at some lateral flexion here. If I laterally flex to the right side has to go down. And for that to go down, we have to have the left side go up. So if we have restriction at one facet joint along the spine, because it takes a little bit of motion at all the joints to create your full motion that you'll measure with the goniometers and inclinometers, then you're going to have pain. And there's so many different connected joints that it's super easy to have one of them cause a lot of problems. Let's go back over to the notes here and make sure we've hit everything on this first vid. Going down here to the next one. Again, we talked about the atlanto-occipital and all of that. We talked about, I didn't talk about the flexion, the actual arthrokinematics of the skull on C1. So there you go, flexion. When you flex, you're going to have an anterior roll, posterior glide, extension, posterior roll, anterior glide. There you go. And the atlanto-axial is rotation only. That's what the dens around the C1 rotating around the dens of C2. So you got some arthrokinematic stuff you can pause and take a look at. And then we talked about the pelvis. So I've mentioned this a zillion times by now, so we should be good with this. We're starting to get good. We need to understand anterior pelvic tilt, what that does to the lumbar spine. It's going to increase lordosis. We get to that position by using our hip flexors and spina recti. We need something on either side, front and back. Posterior tilt is going to decrease lordosis, which is also going to open the IVF, but put pressure on the anterior portion of the disc, pushing it posterior. So if there's been damage to the posterior longitudinal ligament, we might herniate the discs. And we should know that the abdominals and hip extensors are going to help us get into that posterior tilt. We've talked about the discs, pretty good. We've talked about the intervertebral foramen and what increases space there. And we talked about how the nerves are going to exit the IVF. We should understand that our spinal nerve roots are going to carry both sensory and motor. So in one of your other classes, I know you're doing, for example, 2-point discrimination and sharp, dull, light touch. So we got our 2-point, we got soft touch. That's our sensory. We also test motor with our MMTs. We're gonna, in neuro itself, it's a little more specific. We check myotomes versus muscles. And I'll talk about that here in a second. And for our sensation, right now it's pretty crude. You're just kind of doing it anywhere, but we will start doing it on specific dermatomes, okay? So let's take a look at what is a dermatome versus a myotome. This seems to be a tricky spot for a lot of students. So what I'm going to show you here is the ASIA scale. This is the official or the most used way to document spinal cord injury. See if we can get that to unblur. It's like super blurry. If that stays like that, I'll just show you in the next one. Yeah, it's going to stay blurry for some reason. So I'll get a better picture, and that'll be in video 2. And that's where we'll start video 2, with a better picture of the ASIA scale that's not blurry, to show you the difference between myotomes and dermatomes. So I'll see you over in the next lecture.